We'll turn our attention now to multicellular parasites, the helminths. As a reminder from MOD, helminths include the roundworms, which are nematodes, as well as flatworms that include trematodes and cestodes. Some of this will be familiar from MOD, but we will expand to some degree the clinical picture as well as treatment. Much of our discussion today will involve the gastrointestinal roundworms, the nematodes, but we'll touch on the trematodes and cestodes as well. While we cannot cover every topic here, we will highlight some that are important to remember. A few principles to consider include that many patients with gastrointestinal helminthic infections are asymptomatic. Additionally, travel history is very common in patients with helminthic infections. Also, you may be aware that helminthic infections often are associated with elevated eosinophils or eosinophilia. This is specifically true if the parasites leave the GI tract into other tissues in the body. As such, some helminths that remain only in the GI tract do not lead to elevated eosinophils. The first three nematodes that we will discuss all have both a pulmonary phase of infection with potential cough, followed by an intestinal phase. In our first case, we have a 24-year-old male with a cough and gastrointestinal symptoms. He spent the summer traveling in Cambodia, which is considered tropical Asia, where he camped under poor sanitary conditions. While in Cambodia, he started to have a dry cough and some associated shortness of breath. 2 months later, now back home in the United States, he starts having some mild gastrointestinal symptoms with nausea, abdominal discomfort, diarrhea, and anorexia. This leads up to him passing a worm in his stool, similar to the one in this picture here. This is a case of Ascaris lumbricoides, or giant roundworm. As previously mentioned, Ascaris lumbricoides has both a pulmonary phase and an intestinal phase. Dr. Hillard will be discussing the life cycle of this parasite to help us better understand. During the pulmonary phase, patients have a dry cough with shortness of breath and may have lung infiltrates on chest x-ray. Following that, during the intestinal phase, they may have nonspecific gastrointestinal symptoms, such as abdominal discomfort, nausea, anorexia, and diarrhea. As we discussed in this case, patients may actually pass visible worms in their stool. If they have a significantly large worm burden in their intestines, it can actually lead to a small bowel obstruction. So another way you may see this patient present in a case is a patient who migrated from an area where Ascaris lumbricoides is endemic and then presenting with a small bowel obstruction. It's the most common intestinal helminth worldwide and is common in humid, tropical, and subtropical areas. While traditionally it may have occurred in the southeast United States, it's now less common in the United States since improvement of sanitation methods. It's transmitted through ingestion of eggs, fecal-oral route through food or water, and it typically is associated with poor sanitation. In areas where it's common, it can occur chronically and lead to malnutrition and growth retardation in children.
Throughout this lecture, we will be reviewing the life cycle of several parasites, many of which you have seen in MOD. These life cycles are important to know only to the degree that they help reinforce the clinical and/or pathologic findings. The nematodes, or intestinal roundworms, are a class of parasitic helminths, and some, like Ascaris lumbricoides, Necator americanus, and Xylostoma duodenale, and Strongyloides stercoralis, have both lung and intestinal involvement. Ascaris lumbricoides is a large worm, with some females measuring up to 19 inches long. Its life cycle in humans starts with the ingestion of an egg, which releases larvae in the intestine, which then penetrate the intestinal walls, enter the bloodstream, and are coughed up from the lung, where they are swallowed to complete the life cycle.
In our next case, we have a 14-year-old male with cough and GI symptoms. He's from a community in southern Alabama, which is southeast United States. In his community, there's poor sanitation. The patient frequently walks outside barefoot and notes developing an itchy rash between his toes. This resolves after a few days, but a few weeks later, he develops some mild cough. Several months later, he started having epigastric pain, nausea, and diarrhea. His labs show an iron deficiency anemia. This patient has become infected with a hookworm, the two notable species of concern being Necator americanus and Cyclostoma duodenale. In the case of the hookworms, classically patients develop a pruritic rash between the toes where the larva penetrates the skin. Again, similar to Ascaris lumbricoides, Necator americanus and Ancylostoma duodenale both have a pulmonary phase and an intestinal phase. During the pulmonary phase, patients often have a mild cough, which later is followed by the intestinal phase with nausea, vomiting, epigastric pain, and diarrhea. One of the key clinical features here is that it often causes an iron deficiency anemia due to the parasites hooking onto the small intestines, leading to chronic blood loss. Again, this typically occurs in humid areas, including the tropical and subtropical areas, often in the Americas or in Africa. United States numbers have dramatically decreased with improved sanitation, but there still are some locations in Southeast United States where Necator americanus can be present if there's poor sanitation practices such as inadequate sewage disposal. Note the transmission of the hookworms occurs through the larva penetrating the skin, typically on bare feet.
Hookworm species Necator americanus and Ancylostoma duodenale both have the same life cycle and differ from Ascaris in that they initially infect via larvae in the soil, which penetrate the skin to gain access to the bloodstream and ultimately end up in the lungs, where they are coughed up and able to reach the small intestine when swallowed, where they pass eggs into the soil to complete the life cycle. Note that the penetration of skin is a key difference, leading to the itchy rash seen clinically.
This next slide is for your information only, as this may come up in practice or on your boards. The organisms we've discussed so far, and will continue to discuss, specifically infect humans. There are, however, similar species that affect animals, such as dog or cat hookworms. While these animal hookworms can lead to a limited infection in humans, humans are not definitive hosts, which means that the parasites do not fully mature within humans. Specifically, they never go on to an intestinal phase and complete the life cycle. Similar to Necator americanus and Ancylostoma duodenale, dog or cat hookworm larvae can penetrate human skin. However, mostly they stay in the epidermis and cannot break through the basement membrane. This can lead to a linear track under the skin from the migrating larva, referred to as cutaneous larva migrans. This is an itchy, serpiginous rash, usually in the lower extremities, and can be treated with antiparasitic medication, but typically resolves even without treatment. Occasionally they can get deeper and rarely involve the lungs. However, this is self-limited and requires no treatment. Again, it does not progress onto an intestinal phase. Now, I don't want you to focus too much on this, other than to be aware that it can occur with humans becoming infected with dog or cat hookworms. Next, we have a 34-year-old female with cough and GI symptoms. This patient recently returned from a trip to Brazil where she walked outside barefoot. She noticed an itchy rash between her toes and about a month later started having a mild cough. A month after that, she started having GI symptoms with epigastric pain, nausea, diarrhea, and anorexia. You can note the similar presentation overall to our last case with hookworms. Following this patient's GI symptoms, she developed a migratory raised linear itchy rash on the trunk and thighs. This patient is infected with Strongyloides stercoralis, also known as threadworm. Fairly similar to the hookworms, Strongyloides can cause a pruritic rash between the toes where the larva penetrates the skin. It also has a pulmonary phase with a dry cough, which can include hemoptysis, coughing up blood, followed by an intestinal phase with nonspecific nausea, vomiting, epigastric pain, diarrhea, or constipation. Up until now, Strongyloides sounds very similar to the hookworms. One important differentiating factor is that Strongyloides, but not the hookworms Necator and Ancylostoma, can lead to autoinfection, as Dr. Hillard will discuss in a moment. Autoinfection occurs when the intraintestinal larvae penetrate the small bowel or perianal skin and ultimately find their way back to the lungs. This can lead to chronic infection. It can also lead to a linear rash known as larva currens, which results from larvae migrating through the subcutaneous space during autoinfection. Now, don't confuse this with the very similar cutaneous larva migrans that can occur when humans become infected by dog or cat hookworms. With larva currens, the linear rash occurs after the intestinal phase as part of autoinfection. Common locations for this rash are the lower trunk, thighs, and buttocks. In immunocompromised patients, autoinfection can become accelerated and lead to what is called hyperinfection, with pronounced symptoms in the skin, GI tract, and lungs. Similar to previous helminths, Strongyloides typically occurs in hot, humid regions, such as the tropics or subtropical areas. Southeast Asia, Africa, and Brazil are examples. Again, like the hookworms, transmissions through the larva penetrating the skin, typically on bare feet.
Strongyloides stercoralis, also known as threadworm, has exactly the same life cycle as hookworm, except the nematode does not pass eggs into the stool. Rather, immature larvae are passed into the feces and ultimately form a focus for infection for the parasite in the soil. Also, Strongyloides stercoralis, unlike hookworm, can auto-infect the lung from the small intestine. The most important thing to remember from the life cycle, however, is that just like the hookworm species, Strongyloides stercoralis has both skin and lung manifestations.
The next two nematode cases have some similarities and are often grouped together. Specifically, they have a very similar life cycle that involves only the GI tract, and thus they don't have extraintestinal manifestations. Additionally, they don't typically lead to elevation in eosinophils as they don't leave the GI tract. Here we have a 6-year-old male with complaint of protruding rectum. He recently migrated from Vietnam, which is a tropical country. He's been having some mildly loose stools with a small amount of blood in it. Parents note that his rectum seems to protrude after bowel movements. Additionally, there appears to be worms seen on the rings of his protruding rectum. This is a case of Trichuris trichiura, also known as whipworm. While Trichuris trichiura often is asymptomatic, it can lead to loose stools that may have blood or mucus in it, which in turn can lead to a secondary anemia. A key feature of this is a risk of rectal prolapse in which the mucosa of the rectum protrudes out of the anus, with the worms visible in the rectal mucosa. It's usually found in tropical regions or in travelers or migrants from such regions. It's spread through fecal-oral route as a result of poor sanitation.
Trichuris trichiura is also known as whipworm, as the mature adult form of this nematode roundworm has a long whip-shaped structure at one end. Interestingly, the whip actually forms the anterior aspect of the worm. The other morphologic feature that is occasionally asked about is this parasite's eggs. The eggs, which can be identified on an ova and parasite test with iodine stain, have almost a football shape to them, with a set of hyaline plugs on opposite ends.
Next, we have an 8-year-old female with perianal itching. It seems to be worst at night, leading to poor sleep. She has a sibling in her household with similar symptoms, and parents note that when they look at her anal region at night, they see thin, white, cotton-like worms coming out of her anus. This is a case of Enterobius vermicularis, or pinworms. Enterobius vermicularis is a common cause of nocturnal perianal itching, also known as pruritus ani, most often seen in school-age children. On inspection of the perianal area, you may see excoriations and inflammation. When inspecting at night, you may see female worms that appear as thin, white, cotton-like threads at the anal verge, where the end of the anus meets the skin. Often during the day, the worms may disappear back up the anus and cannot be seen. The classic diagnostic test for this is the Scotch tape test, in which you place a piece of Scotch tape over the anus to collect eggs laid by the females. The tape is then transferred to a slide where you can then see the eggs under a microscope. It's important to note that stool, ova, and parasite test tends to not be helpful here as the eggs are not typically passed into the stool. Pinworms are present in both temperate and tropical climates, and in fact is the most common helminthic infection in the United States and in Western Europe. While the other helminthic infections are much more likely to be seen in travelers or migrants from other countries, you're very likely to see pinworms in patients in the United States without a history of travel. As we mentioned before, it's common in school-age children. It's spread through the fecal-oral route, from hand to mouth, which can include self-reinfection, as well as spread from person to person. Hygiene is key in management and prevention, including washing bedding, clothing, and treating the whole household. This is diagnosed clinically, and we will not have any specific further pathology discussion on it today. Next, we'll talk about a 45-year-old male with myalgias and weakness. He ate some undercooked pork about 3 weeks ago while at a party where friends were serving pork from a feral hog. He then developed nausea and vomiting with diarrhea 2 weeks later. Now he's having myalgias, fever, weakness, and facial swelling. Several others at the party have similar symptoms. His CBC shows eosinophilia. This is a case of Trichinella spiralis. Symptoms from trichinella begin with GI complaints of nausea, vomiting, diarrhea, and abdominal pain. Patients then develop muscle symptoms of myalgias, fever with associated weakness, and periorbital edema. Like many of the helminths that have extraintestinal involvement, trichinella can lead to elevated eosinophils during the larval migration. Diagnosis is made through muscle biopsy. This can occur worldwide and is transmitted through ingestion of undercooked meats of animals that are infected by trichinella. As this far side comic alludes, pork is a classic source of trichinella, but it can also occur from wild game, of course including feral hogs, but also bear and walrus.
Transmission of trichinella species, including Trichinella spiralis, involves eating raw meat from contaminated animals, which contain encysted larvae. Once swallowed, these larvae travel to the intestine, where they mature and have larvae of their own, which burrow through the bowel wall and encysted in the muscle of the infected person. The top right photomicrograph here shows what would be seen on muscle biopsy with numerous larval forms of Trichinella spiralis. The lower two pictures show sections of larval forms in cross-section at higher power. So now we can update our comparison chart to summarize the major features of the intestinal roundworms. Both the ones which cause lung involvement appear at the top, and the ones which infect the gastrointestinal tract without lung involvement here at the bottom. Please use this table as a way to compare the intestinal roundworms, including unique clinical features of each.
We can alter this table to include the workup and treatment. A few things to notice include that Trichuris and Enterobius do not typically lead to eosinophilia as they don't leave the GI tract. Also note that these top four organisms can be diagnosed through ova and parasite test. However, Anaerobius often is diagnosed through the Scotch tape test and Trichinella through a muscle biopsy. Now we've not yet discussed much the treatment, but you should note that any of these parasites can be treated with the benzimidazoles, which include albendazole and mebendazole. Two other antiparasitic drugs include parental pemoate here, which can be used for the hookworms, or for Enterobius pinworms. Additionally, ivermectin that can be used for strongyloides.
Benzimidazole is a heterocyclic aromatic organic compound. The benzimidazole group is commercially used in fungicides. Proton pump inhibitors also utilize the benzimidazole group, omeprazole, for example. Other pharmaceutical drugs which contain a benzimidazole group include galaterone, a steroid antiandrogen. Benzimidazole derivatives are among the top frequently used ring systems for small molecule drugs, listed by the U.S. Food and Drug Administration. There are three anti-helminth bendazole-containing compounds: albendazole, mebendazole, and thiabendazole. All three have the central benzimadazole ring. Thiabendazole is fraught with side effects, so it's not heavily utilized. Mebendazole is not approved for use in the United States. Albendazole is the main drug used in the United States. Albendazole is an oral medication for parasitic worm infestations of the type shown here. There are common side effects: nausea, abdominal pains, and headaches. There are potentially serious side effects to include bone marrow suppression, although this improves on stopping the medication. Liver inflammation. Patients with prior liver problems have a greater risk of having liver inflammation. This drug is a pregnancy category C. It may cause harm if taken by pregnant women. It was developed in 1975 and is on the WHO's list of essential medicines. Let's talk about these antiparasitic drugs' mechanism of action. From a pharmacokinetic standpoint, albendazole is poorly absorbed. Hence, this drug lingers in the lumen of the intestine, making it ideal as a treatment for intestinal infections. Recall that microtubules are formed by an alpha-tubulin and a beta-tubulin dimer, and microtubules are constantly forming and being broken down to aid in motility and cellular architecture. It turns out benzimidazoles block microtubule assembly, specifically in the parasite. Digging a little deeper into these drugs' mechanism of action, specifically, they bind to the colchicine binding site of beta-tubulin. Colchicine is a well-known microtubule inhibitor. These drugs block the polymerization of alpha and beta-tubulin dimers, specifically in intestinal cells of parasites. This has the net effect of reducing glucose uptake through the GLUT2 transporter, which is microtubule dependent. This has a huge effect on the digestive and reproductive capacities of parasites. These drugs immobilize the parasites, hinder their egg production, and ultimately produce death of the helminth. Resistance is observed, and the mechanism is mutations specifically in beta-tubulin protein that decreases binding to beta-tubulin. Parental pamoate, discovered in 1965, is a broad-spectrum oral medication. The structure is shown here. This drug treats parasitic worm infections to include ascaris, hookworm, and pinworm. Here's a picture of some pinworm. Side effects include nausea, headache, dizziness, trouble sleeping, and rash. As a point of caution, lower doses of this drug should be used in people with liver disease. It doesn't appear to be harmful during pregnancy, but it's not been studied. It's unclear if it's safe for use during breastfeeding. This drug is poorly absorbed by the patient, again, so it treats luminal helminth infections because it lingers in the intestine. Its mechanism of action is it's a depolarizing muscular blocking agent in the parasite. That is, it's a cholinesterase inhibitor. This causes sudden contraction followed by paralysis of the parasite. This causes the worm to lose its grip on the intestinal wall. Worms will usually pass in the normal stool or with diarrhea, straining, and occasionally vomiting. This drug can induce complete intestinal obstruction in your patients that have a very heavy worm load. Heavily parasitized patients can become impacted. Ivermectin. Discovered in 1975, its use was restricted generally to farm animals, with approved for human use in 1987. Ivermectin can be taken orally or intravenously or even applied to the skin for external infestation. Originally, this drug was used in veterinary medicine to prevent and treat heartworm and ascariasis. In humans, this drug is now being used to treat the indications shown here. Here's the structure of ivermectin. And here's the structure of ivermectin bound to a transmembrane glutamate receptor in C. elegans, or worms. Glutamate-gated chloride channel receptors, or GLU-CLRs, mediate inhibitory neurotransmission at invertebrate synapses. Ivermectin is a broad-spectrum pesticide that binds and potentiates glutamate-gated chloride channel receptor activity. More broadly speaking, ivermectin's mechanism of action is that it interferes with the nerve and muscle functions of helminths and insects. It does so by binding to glutamate-gated chloride channels common to invertebrate nerve and muscle cells. It turns out glutamate-gated chloride channel receptors are not present in vertebrates, and as such are thought to confer the broad safety margin of ivermectin. Again, this has the effect of pushing the channels open, increasing the flow of chloride ions, hyperpolarizing the cell, and affects nematode motility, feeding, and reproduction. Parasites end up dying of starvation. Briefly, during the COVID-19 pandemic, misinformation has been widely spread claiming that ivermectin is beneficial for treating and preventing COVID-19. As a matter of fact, the FDA, CDC, and European Medicine Agency have stated that ivermectin is not authorized or approved to treat COVID-19. However, this drug has been used safely by hundreds of millions of people to treat river blindness and lymphatic filariasis.
As we continue our discussion about helminths, we should mention the trematodes, also called flukes. Schistosoma, the primary trematode you should be aware of, was covered well in MOD, and this table comes from your MOD lectures. Now, we won't go into further detail other than to say that the workup for intestinal trematodes is with stool, ova, and parasite test. Treatment for all trematodes is with praziquantel. Unfortunately, while treatment can help prevent progression to chronic organ damage, it does little to reverse the late-stage chronic changes of the liver and urinary system. We'll turn now to the cestodes or tapeworms. Similarly, the cestodes Tinea solium and Tinea saginata were well covered in MOD, and we'll just mention here that likewise they are diagnosed through stool, ova, and parasite test. Tinea is identified by the eggs or proglottids in the stool. Additionally, they're treated with praziquantel. One exception here, however, is that neurocysticercosis due to teniosolium is treated with albendazole. We'll take time to discuss further, however, about two additional cestodes, Diphyllobothrium laudum and Echinococcus granulosus. In this case, we have a 47-year-old male who presents with nonspecific fatigue and numbness. He reports his fatigue's been slowly progressive. Additionally, he's having pins and needles or paresthesias in both his feet. He's also been having some mild associated diarrhea. He notes that he's an avid freshwater fisherman and frequently eats what he catches, sometimes as sushi. Diagnostic evaluation shows a megaloblastic anemia with low vitamin B12. This patient has Diphyllobothrium laudum. Diphyllobothrium laudum, also known as fish tapeworm, is the largest human tapeworm. Patients may present with nonspecific symptoms of fatigue, dizziness, diarrhea, and numbness. One of the key features of this is vitamin B12 deficiency, as the tapeworm competes for vitamin B12 in the intestines. More advanced vitamin B12 deficiency can lead to megaloblastic anemia and neurologic symptoms including symmetric neuropathy. Not all patients develop megaloblastic anemia and neuropathy, but many will have low vitamin B12 levels. Additionally, patients may have an eosinophilia. Interestingly, similar to Ascaris lumbricoides, patients have a risk of bowel obstruction if the worms get tangled up upon themselves. Diphyllobothrium laudum occurs from ingestion of larvae in raw freshwater fish such as in sushi, and when not treated, adults can live about 10 years in the human intestines. Workup includes ova and parasite test, with treatment being with praziquantel. Please keep in mind that praziquantel is the treatment of all of the trematodes and cestodes that we've covered so far.
Praziquantel, also known as biltricide, was discovered in 1982 and it's an anti-helminth. It's on the list of WHO list of essential medicines. Works partly by affecting the function of the worm's sucker, specifically by increasing the permeability of the membranes of the schistosome cells towards calcium ions via the target voltage-gated calcium channels. Here's the structure of praziquantel. In humans, it's used to treat these indications, in particular schistosomiasis. This drug is not for worm infections of the eye. Side effects include poor coordination, abdominal pain, vomiting, headache, and allergic reactions. This drug is safe during pregnancy, although it's not recommended for use during breastfeeding. From a pharmacokinetic standpoint, praziquantel is well absorbed from the GI tract. However, there's extensive first-pass metabolism, therefore only a relatively small amount enters systemic circulation. This drug is mainly excreted renally. It's heavily metabolized through the CYP-P450 pathway via CYP3A4. Therefore, agents that induce or inhibit CYP3A4 to include phenytoin, rifampicin, azole antifungals will strongly affect the metabolism of praziquantel.
In this last case, we have a 50-year-old woman who presents with right upper quadrant abdominal pain and vomiting. She's originally from Peru and moved to the United States many years ago as a young adult. She's now having gradual onset of right upper quadrant abdominal pain. She has some intermittent nausea and vomiting as well. On examination, you note hepatomegaly. Labs indicate both eosinophilia as well as elevated liver tests. Imaging shows a large cyst in her liver, the image here being from a CT scan. This is a case of Echinococcus granulosus. Before we discuss further the clinical details, Dr. Hillard will cover the life cycle and pathology.
Echinococcus granulosus is a tapeworm or cestode. Although the exact life cycle and stages of the parasite are not important to memorize, you should know that the disease is caused from direct ingestion of an embryonated egg found in fecal material from dogs. Also of note, sheep serve as an indeterminate host. Dogs get infected after ingesting cyst material from the organs of a sheep. Roaming and stray dogs in particular have been known to hunt and kill sheep. In humans, once the egg is ingested, it will hatch, releasing an intestinal penetrating parasite which can encyst in various organs. The liver is the most common site, followed by the lung, but any organ can be affected. The gross pathologic findings correlate to what is seen radiologically in that a large, thick-walled cyst often forms, preferentially in the liver and then the lung. If the cyst ruptures, multiple smaller daughter cysts can form with the infection. On histologic examination, refractile hooks can be seen which can provide a definitive diagnosis. Here we see a red-brown liver specimen with a large hepatic cyst, and here we see a stained adult Echinococcus organism. And if we look closely at the front, we will see a ring of hooks. And finally, on histologic examination, you will see numerous small cysts. And if we look in these cysts, there are parasitic forms in cross-section in which refractile hooks can be identified.
Patients infected with Echinococcus granulosus are usually initially asymptomatic, and the infection may actually be latent for over 50 years. Patients can develop what are called hydatid cysts, the name given these parasite-filled cysts that occur in extraintestinal organs, with the liver being the most common, followed by the lung. These cysts can become calcified, and the calcifications are sometimes referred to as eggshell calcifications. Symptoms usually develop when the cysts become large, and in the liver can lead to right upper quadrant pain, nausea and vomiting, and hepatomegaly. Importantly, the cyst can potentially rupture, which can lead to local symptoms. For instance, if a liver cyst ruptures, it can affect the biliary system. Additionally, rupture cysts can lead to an immune response with anaphylaxis. Echinococcus is transmitted through ingestion of eggs, specifically from dog feces. You typically will see this in immigrants from areas such as South America, the Middle East, Africa, China, or the former Soviet Union. Workup includes imaging, which can be ultrasound, CT scan, or MRI with findings of cysts in the liver, or potentially lungs or other organs. Additionally, diagnosis can be through serology, which is antibodies against Echinococcus. Ultimately, aspiration of or biopsy of the cyst can be diagnostic, with findings such as those described by Dr. Hillard, including refractile hooks. Please take note that while the other cestodes are treated with praziquantel, Echinococcus is treated with albendazole. Additionally, surgery can be performed for complicated cysts. Here we have a summary table of the flatworms or platyhelminths. Remember, this is a great resource to study from. However, don't forget to review the other slides as well. I'd like you to focus on these last two organisms, Diphyllobothrium latum and Echinococcus granulosus, recognizing the key features. Also review the workup for all of these, and recognize that all of them can potentially lead to eosinophilia. Lastly, don't forget to review the treatment and note that praziquantel can be used for all of these organisms except for Echinococcus. Echinococcus should be treated with albendazole. Remember, albendazole can also be used for any of the nematodes and should be used for neurocysticercosis.